Hello, let's discuss this question. A 28-year-old man comes to the office for evaluation of a left testicular mass. The mass has been present for 2 months and has increased in size. He has had no pain in the affected testes or weight loss. He is otherwise healthy and has no other symptoms. The patient does not use tobacco, alcohol, or illicit drugs. Vital signs are normal. The abdomen is soft and non-tender with no palpable masses. A painless hard nodule is noted in the left testicle. There is no inguinal lymphadenopathy. Scrotal ultrasound reveals a solid hypoechoic 5 centimeter left testicular mass. What is the next best step in the management of this patient? So this 28-year-old male, okay, presented with left testicular mass, and the mass is painless and hard, and on the scrotal ultrasound it reveals a solid hypoechoic mass. Okay, so the painless hard and solid hypoechoic mass on the ultrasound, it suspect the left testicular cancer. So when there is mass, painless and hard mass, and the ultrasound shows the solid hypoechoic mass, then we would consider the testicular cancer. Okay, and to diagnose the testicular cancer, first we will do the scrotal ultrasound, then we will do the serum markers like beta HCG, alpha fetoprotein, LDH. Okay, and then we will also do a diagnostic and the therapeutic intervention, which is the radical inguinal orchidectomy. Okay, so radical inguinal orchidectomy is both diagnostic and therapeutic. Okay, so it can be used for diagnostic purposes as well as therapeutic purposes. So in the patient with left testicular mass, painless and hard mass, and ultrasound shows the solid hypoechoic mass, then we will consider the testicular cancer, and the best next step will be to do radical inguinal orchidectomy. Why we cannot do the transscrotal biopsy? Because when we give the scrotal incision and give either do biopsy or do scrotal orchidectomy, then there is chances or risk of the spread of cancer through the lymphatic system. Okay, so we will not do the transscrotal biopsy. In the testicular cancer case, never do the biopsy because it raises the risk for the spread of the cancer. Then the first option is androgen deprivation therapy. So androgen deprivation therapy cannot be used in the testicular cancer. Instead, it is used in the prostate cancer and the disseminated prostate cancer. Okay, so it is used in the disseminated prostate cancer. And then the second option, B option, is antibiotic and re-examination in 1 month. This antibiotics is given in the case of the epididymoarchitis, not in the testicular cancer. And in the epididymoarchitis, the scrotum is or the testes are painful, okay, not painless. While in this case, the mass or the testicular mass is painless. Okay, fine needle aspiration cytology, it is also not cannot be done in the testicular cancer. Okay, so the correct option is radical inguinal orchidectomy. Okay. The correct option is radical inguinal orchidectomy. So, testicular cancer, epidemiology of the testicular cancer, it occurs at the age range of 15 to 35. Risk factors include the family history and crypt orchitism. Then the types of the testicular cancer, it can be germ cells tumor, which contribute to 90% of the testicular cancer. The germ cell tumor can be seminomatous, okay, which is called seminoma, or non-seminomatous, which include the embryonal carcinoma, yolk sac, choriocarcinoma, teratoma, and mixed cell carcinoma. Then the other type of the testicular cancer, it can be sex cord tumor, sex cord stromal tumors, which include Sertoli cells tumor and Leydig cells testicular cancer. Okay, manifestations will be unilateral painless testicular mass. It can also present with dull ache in the lower abdomen. Diagnosis can be done by examination, which shows the firm ovoid mass. Then the serum markers can be elevated like alpha fetoprotein, beta HCG, and LDH, and scrotal ultrasound can be done. Okay, so this is about this question.